Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon. Today's episode is titled Protecting Joints, Inhibiting Structural Damage in Psoriatic Arthritis with Guselkumab. And we're taking a closer look at how this IL-23 inhibitor fits into the treatment landscape for psoriatic arthritis, particularly when it comes to slowing or preventing structural damage. Obviously, something that's really important to us. We obviously want the medication to work, and we want patients to feel better, but we also want to make sure that we are inhibiting that structural damage from happening because, as you know, once it happens, we can't take it back. Joining me today is Wendy Simmons, a trusted colleague and friend. She's an experienced clinician. She really is like the OG of rheumatology APPs. And she, of course, is one of our RhAPP board members. Wendy, would you mind giving our listeners a quick introduction?
Amanda, thank you so much. I always enjoy sharing and doing podcasts with you as well. I'm Wendy Simmons. I'm a physician assistant in Wilmington, North Carolina at Carolina Arthritis Associates. I've been in the practice 28 years of rheumatology. I've enjoyed every minute, still enjoy.
So incredible. So incredible. I know. I think I'm going to actually stop telling people how long I've been in rheumatology because I feel like it's aging myself. But, we're so excited to have you here. And I know this will be super beneficial for our listeners. So thanks again. Together, we're going to explore the clinical data behind Guselkumab, real-world considerations for its use, and how this treatment option may support long-term joint preservation in patients with psoriatic arthritis. So let's go ahead and just dive in. I'm going to ask you a few questions, and then we can kind of work our way through it. So to start us off, can you briefly describe the importance of structural damage prevention in psoriatic arthritis and how it influences long-term outcomes for patients?
Yes, Amanda, this is actually dear to me, close to home. When I started rheumatology around 1997, that was the time that we were starting to see the biologics come out, right? And, I was with 3 rheumatologists and they do a lot of radiology in the practice. So I was learning that as well. And I don't know if it's good to say I was fortunate or unfortunate to see one of the patients, one of the rheumatologists, the lady that had psoriatic arthritis and actually had progressed to the point where she had arthritis mutilans, and that's where, I feel that it's important we all understand, the process where there's so much inflammation along where those ligaments and tendons insert into joints along, the shaft, and they cause a periosteal reaction. So much inflammation, it can erode that joint to the point where, the lady's joint had collapsed, where it's telescoping, and can be progressive. And, it's sad that I saw that case, but, in retrospect, it really impressed on me what that disease can do because you don't always think some inflammation can cause that. So this is also a very destructive process that requires biologics now that we have them available.
You're so right. I mean, I'm fortunate. I'm trying to think if I've even had a patient where I've seen that. I've definitely seen the severe joint damage happen. And that's one of those classic things that you see in the textbooks. Yeah. And, we're so lucky that we don't really see that anymore because of the era of the biologics. Also, how cool that you have been doing it since 1997 when the first biologics really started. I mean, that's so cool.
Seeing both sides of it there as well. But when you talk about the importance also of the structural damage prevention, I think that we need to remember that this can happen quickly. This can happen, within 6 months. So whatever point that you're evaluating your patient, that you develop that relationship, it's important to be keeping, the potential structural damage in mind that could happen to that patient because it will, their outcome.
Yeah. And, it's, again, since you have been in it so long, you've seen, all of the biologics really get approved for this disease. So let's talk specifically about Guselkumab and where it fits within the kind of the current psoriatic arthritis treatment landscape for you.
Absolutely. Well, this does lead right into that as well, and the great fit that Guselkumab has with these patients as well. And I would dive right into the recent APAC data that we've had. that's really been able to show us through the clinical trials that there is the ability for inhibition of joint space narrowing, structural damage, progression, as well as, good clinical outcomes and safety with the patient. So I feel that, we do see that. I know Dr. Meese presented that at the EULAR Congress recently. So a lot of exciting data there to position it there for our patients when we're thinking about halting the disease inflammation in its tracks, preventing that progression to structural damage.
That's incredible. And I always try to think about would I prefer one medication over another medication, and particularly in the disease of psoriatic arthritis? And what I would say is I think it's so wonderful that we have so many options, and we really do practice kind of this domain-based approach where what works for one person because of these particular domains. Let's say they have psoriasis, the inflammatory arthritis and Crohn's, or, because obviously a lot of these people are kind of this overlap. It's so lovely that we have, these options that really can fit to each patient. Mm-hmm. Now, obviously we're specifically talking about radiographic inhibition. What do we know from the clinical trials of Guselkumab and its ability to inhibit that?
Right. Well, we know that certainly, in both, using doses every 4 weeks, every 8 weeks, we see, those outcomes, that were positive. Primary endpoints were met at week 24, those major secondary endpoints, with that reduction of joint space narrowing and clinical, progression, in those patients. But at the same time, with maintaining that, safety and efficacy with the clinical outcome. I think that's important. When we're looking at everything in our toolbox as well, we have to do our due diligence with safety, efficacy, and I know we'll be talking also, patients with comorbidities and other things as well. So there were a lot of positive identifications out of that APEX trial, for those patients and structural damage reduction.
It's really nice to know that, again, if we use this medication, we are stopping the progression of the disease in multifaceted, it's multifaceted, meaning, not only can we stop the radiographic progression, obviously the patient can feel so much better, but it can also potentially help with some of these other domains that I talked about. So when you're looking at a patient for Guselkumab, how do you approach that? How do you identify patients that might benefit, particularly those that might be at risk for structural damage?
Yeah. So I think that every patient that does come across our path, we need to be thinking, that is a potential outcome. I had another patient a while back. She came to me, had been on, biologic, and had recurrent infection. So when I met her, that was the conversation. I am not taking any more biologics. And she had the documented visits with infections. And for her, that wasn't necessarily the best fit at that time. So we, certainly tried the, DMAR, methotrexate, PD4. If she wanted to try to maintain, limiting progression and control of her disease without the biologics. And then sure enough, one day she showed up in clinic with a left elbow flexion deformity. And this can happen on any therapy almost. Like you say, this is a disease with multiple domains. What we see on initial evaluation with the patient, we might see only a few of those domains. However, when they flare, it could be a whole set of other domains. So we have to keep that in mind. So then we think about what are those tools in the toolbox. Really, having that solid data of limiting radiographic progression does help when you are thinking of that. You don't necessarily want to wait for a patient to walk in with a flexion deformity or something else where you can see that disease is active. But it's nice. And then you also mentioned, Crohn's disease, ulcerative colitis. And I really have got this huge interest lately, in that triangle, the psoriasis, psoriatic arthritis, and inflammatory bowel disease. I have two patients, one with Crohn's and one with ulcerative colitis, that actually, the GI has sent me. One was on, infliximab infusions. We know that 30% of those patients potentially can actually develop, psoriasis, psoriatic arthritis, on infliximab. The patient had to cycle through a couple of biosimilars. And then at that point, after multiple gut biopsies, the gut's controlled, the GI docs, like, you treat her scalp psoriasis, dactylitis, Achilles tendonitis. And so we're now learning how all these diseases do come together as well. So some of these biologics that we have, we want to look at, what are the indications? What are the data coming out of the clinical trials? But for us, in rheumatology, that space narrowing and damage is definitely important in an active disease as well.
What are the clinical features or potential comorbidities that might push you towards or away from choosing Guselkumab in practice?
Certainly, if you were to immediately say, away, you would think if, maybe the patient had been referred from dermatology, maybe the patient had been on this medication, had a hypersensitivity reaction. If there's some form or would be some form of intolerance, that certainly would be something for you to think about as well. Certainly a lot of positives to drive you towards, whether using, bio-naive, bio-experienced, first line. What is nice is the safety profile. We do our due diligence with safety and efficacy in all our medications in our toolbox. That here we're seeing excellent safety profile as well. And then many of our patients have comorbidity. So that's something else certainly for us to consider when we're choosing medication. Some of them already have inflammatory bowel disease. So we want to look at, what is their past history? Maybe they have frequent flares, and we need to look at what are the triggers, stress, environmental triggers. Then I also think it's really important that we look at other coexisting inflammatory arthritis that could be with psoriatic arthritis, like gout, for example. We don't want to discount any of our therapy, though they don't work anymore. Maybe it's not psoriatic flare. Maybe it's a gout flare as well.
Yeah. Or even just osteoarthritis. Like I have this conversation, like 2 or 3 times a week where I'm telling people, no, I actually think your inflammatory arthritis is controlled. I think where you're having that more pain in your CMC joint is probably more your osteoarthritis. So, I think setting the tone for patients, I think is important too, just to try to figure out what actually is going on. And I totally agree with you. I think obviously the no-brainer is that patient that has concomitant IBD, because this medication will work for that as well. I think, the other thing I would think about is, do they have a cardiovascular history? I mean, I would push towards this one versus maybe some of our other options, when thinking about that as well. The only one that I think would come to me in terms of like pushing away, you're right. Obviously, if they've had like some previous, issue with it, but be maybe like the uveitis patients, because I don't know if there's data, for this, but I might, if it's a new patient, they've got uveitis and psoriatic arthritis, I probably would gear more towards like, the monoclonal TNFs in that particular case.
Yeah, I agree. That's a great point, Amanda, as well. So I think we have our different populations with our patients that are new to us. What have they had? What are the potentials? Then we have those patients that we need to think about, or am I going to, I don't want to push them away if this could be something else, that I'm treating. But there are, our diabetics. Are they having recurrent fungal infections or candida? Are they smoking? Do they have cardiovascular stroke history? So many things for us now that we really need to be astute in thinking when we're considering, these wonderful medications as well. But safety is there, and I think that's important.
Absolutely. Well, so let's shift a little bit to how you talk to patients. I know you are obviously really, really good at this. I've sent you patients that have moved, and I know how much they love you. When you're talking to people and you're talking about the goal of structural damage prevention, how do you have that conversation? How receptive are they to this as kind of a long-term treatment perspective? Because I would assume they just kind of want to feel better. But what are you saying to them?
Yeah. Well, I'm actually pretty direct, and your patients are wonderful. They always continue to ask about you as well. So it's great to have those patients from you. I am direct, and even I don't feel that the amount of experience you have certainly gives you confidence, which you need when you're talking to the patients, especially in this type of situation. But our patients are unique and they all have their questions. But I feel that you do need to be direct. And what I do is I'll use a couple of patient stories, patient experiences, maybe my lady with the flexion deformity, maybe the patient that I had experience with much longer before, there were a lot more biologics in this data. I think being direct, showing your confidence, then also if I can get to the point, if it's a patient that understands, I can talk to them about studies. Look, there's this data here, and that's where we are with that data as well.
I feel the same way.
I hate to get to the point and say, this is a destructive inflammatory arthritis, and this can lead to your joints being destructed and you having loss of quality of life and potentially being in a wheelchair one day. That seems sometimes a little harsh. I did have a mentor rheumatologist that trained me. And I remember that was one day when I was really early on APP in rheumatology. And I was like, oh my gosh, she doesn't want to take this therapy. What am I going to do? And he came down with me and he literally looked at that patient and said, you can end up in a wheelchair. And that was when I learned sometimes maybe you have to be direct with some patients as well.
I agree.
It's hard for our they don't understand connecting the joint and the skin, and then the gut or the eye could be there. And, I really think it's wonderful. And I know you've done a lot of wonderful work with it as well to educate RhAPP and all our APPs is following RhAPPA guidelines. Those are really, really good guidelines. And I just encourage everyone, whether you're new or, a longer practicing APP, just to be keeping those as, on your conscience for guidelines.
Might be a good idea just to kind of print them out and have them at your desktop. That way, especially if you're a newer APP, you can or even us. I mean, I need to reference them too,
Yeah, I agree. I just, it's helpful for me. I never feel like, oh my gosh, I'm seeing this again. I always have a positive attitude. This is fabulous. This needs to be always first and foremost out there. A lot of work put in that, but that does help as a guide, but also keeps us aware of all the different types of presentations. As to your point earlier on, Amanda, it's a heterogeneous disease and different domains, and we just don't always know when or could predict when they're going to come out.
So true. And, again, it is so nice that we have so many of these options. And, I was really excited when Guselkumab came out, and, I work really closely with the Rheumatology PA, and we share 1 million patients, and we both love this medication. I think from a skin perspective, it is so amazing. I often in my experience kind of see the skin start to respond a little bit faster than the joints do. Mm-hmm. And so I kind of set that tone for patients of this is a really great option. We might have to, give it a little bit more time in terms of from the joint perspective, but once they start to see their skin clear, it's pretty amazing.
So Amanda, I think that those are great points. I mean, just all that experience, the skin and, and the joints as well, with these patients. We've got a lot of excited about all the radiographic data.
Absolutely. And, again, just really trying to find that right person for this medication. And, when I'm a big fan of Guselkumab. I remember when it first came out, and I work really closely with this Rheumatology PA, and we share a lot of patients. And, the one thing that I love is that their skin really responds quite fast. It seems like in my experience, I do have to tell people, I think the joints kind of take maybe a little bit longer. So I try to set that tone for patients, so that they kind of understand that, that will improve and we will prevent structural damage, but maybe it, in terms of their immediate response, I do find that the skin kind of responds a little bit faster. So my last question for you, because this is, this particular podcast is definitely about that structural damage. But are there ongoing or recent studies with Guselkumab that you're excited about that could potentially impact the future of how we use it?
Yeah, I have so much excitement around Guselkumab as well. The STAR trial, I like to look at other trials, STAR trial. I'm really interested, in the axial symptoms as well. I know that that trial looked at the patients with psoriatic arthritis and bio-naive, and it's really, I feel like, a current topic, hot topic, going to be an ongoing topic. Where we go with axial symptoms in these patients. I know that can become different. I don't know if we should say difficult. HLA-B27 positivity, or other domains, but I definitely kept my eye on that as well. And then also with recently working with the GI docs, I have 2 of my patients that I am treating, with one with Crohn's and one with UC, but horrible scalp psoriasis, horrible psoriatic arthritis, taking pictures with swollen Achilles tendon, dactylitis, guts completely controlled. So I know, like you said, we're talking about structural damage as well, but there's definitely, this is what we need to think about. And, maybe we're going to be getting closer with our GI colleagues as well, with this medication, to help. But I like to keep my eye on the axial trials and then anything new GI. I think it's going to have a big impact on all of us in rheumatology.
Absolutely. Well, thank you so much for your insights, Wendy. Obviously, you bring so much experience and you've used this medication quite a lot. And I know you can see how it's working just like I do too. So with that brings us to the end of this episode of RhAPPcast. Again, a big thank you to Wendy for joining me today and sharing her insights on Guselkumab and its role in protecting joints in psoriatic arthritis. I'm also excited to see those axial trials and how they're going to continue to progress and, what we're going to see. I think it's going to be really exciting. If you found this discussion to be helpful, please be sure to subscribe to RhAPPcast wherever you listen so you never miss an episode. For more rheumatology-focused education and resources, check out our RhAPP ACE 2.0 app or visit us at rhapp.org, where all digital education is housed in our content room. Thanks again for listening and all you do to take care of patients with rheumatic diseases. We'll see you next time.